through to the next one, please. So just before we get going with the presentations, just a bit of a reminder around our core principles. So People First is what we describe as our quality improvement program within the trust. We've got 3 core principles: respect for staff, value to the person we care for, so very much a big patient focus, and also supporting teams and coaching teams to feel comfortable and be able to drive their own improvement. So there's that kind of real ownership as well. So they're the core principles. So on to the next one. And a reminder of our 5 pillars. So as part of the People First improvement practice, we have what we describe as our quality management system. So teams being clear on their purpose. We like to coach and train teams to do scientific tests of change, so using PDSA cycles, clear processes around how we manage the work, which is the production bit, everyone coming together on a regular basis just to talk about how we're doing, how we can improve the work, which is the improvement huddle, and team health around how we display and demonstrate the right behaviours towards each other in a team setting, and just try and improve how we do some of those team dynamics. So that's a reminder of the 5 pillars. So we'll then move on. So we've got a busy report out. So we've got 6 contributions. I'm very grateful for everybody who supplied their slides and giving up their time as well. Just to manage expectations for the final element of the agenda, which is the stroke rehab unit report out, we're doing our own test of change. So we're going to go live down to Mount Gould for a little bit of an interactive presentation around what's been going on around a particular event down there. We're hopeful that's going to go really smoothly, but it's something we're trialing for the first time. So we'll just see how it all goes. But we're going to go into that with a load of positive intent. But we'll do that right at the end. So if we could just then move on to the next slide, please, Buck. And I think Alice, who I can see is on the call, Alice, you're kicking things off. And as we caught up a few weeks back, I'm really interested to hear what you've kind of been up to around See and Treat cataract surgery. So the floor is yours. Buck will move the slides forward for you. Welcome.
Fabulous. Thank you very much. Can everyone hear me okay?
Yes, we're all good.
Yeah. Lovely. Okay, so I'm Alice Dyer. I'm one of the ACPs in ophthalmology. We're in the REI, and we started a new project on See and Treat cataract surgery. As patients are getting older, their cataracts in their eyes are needing surgery, and we needed to up the capacity to get our patients in and out basically as quickly as possible. We found that we're having too many outpatients appointments, so we came up with this project. So next slide, please. So my first target condition was is how we're going to get the patients into us. So it was a one-stop was what we were looking for. So patients would be referred to us from either their opticians within 4 weeks. We would have to set up clinics. We needed to create a space in our theatre section. I needed to go on a course that I started last year, assessing cataracts. We needed to find the right people. We needed to make sure the equipment was going through. So when all of this was starting, I decided to do a questionnaire to find out actually what the patients liked, whether or not this was something that they wanted to do, whether they wanted to See and Treat, or whether they liked the way that it was set up at the moment. Next slide, please. So this is my questionnaire that was given to the patients. I only decided to do about 50 patients because a lot of them were coming through. So it was given to the patients when they came in for their pre-assessments. So originally the patients would either go to an optician's, be sent to us because they had cataracts, or they were seen in the clinic environment. They would then come back to the clinic, have their measurements taken of their eyes, because everyone has different shaped eyes. We needed to measure patients' eyes to find out what lens to put in the eyes, and then they would come back again to have surgery. So some patients would have 3, maybe 4 appointments with us before having their cataract surgery. Next slide, please. So it was not as good a result as I was expecting. Only 13 patients managed to bring back the questionnaire. That was either because they didn't have a pen or it was lost between the waiting room and coming into having the pre-assessment. I think that patients just put it in their handbags or their bags or their books and just didn't hand it in. The questions that I was finding out was, how far did you live? I was really trying to aim at people who lived a long way from us. So patients who live in Looe spend an awful lot of money coming to us. They might live alone. They might not be able to afford to come backwards and forwards to the clinic at numerous occasions. They might live by themselves, so they can't actually get to us. They need family or relatives to be able to bring them into us. But the outcome of the survey was that patients were happier to have a one-stop appointment. So they come in, are seen, have their cataract done on the same day. So it's all done and dusted in one way. They don't have to talk to any relatives, bring them. They don't have to stop work. And it saves the patients money and time as well, which is one of the main things that we were looking at. Next slide, please. So my second target condition was setting up the pre-assessment clinic. So DRSS is a company who have the referral sent to them, and then they dish out all the cataracts to whether they go to us or they go to New Medica or other areas that deal with cataract surgeries. And we needed to make sure that they were sending us patients as well, and the right patients. So we decided to set up a pilot scheme. So we would have 10 patients, making a phone call to 10 patients, doing their pre-assessments over the phone, sending all the information to the patient so that they had all the information about pre-assessment, about what questions were going to be asked, about what was going to happen in surgery and what was going to happen after surgery as well. So that then when I phone them, they would have a full information and they would have questions already ready for me. So 10 patients were called. I needed to find 8 suitable patients to do operations on the following week. So that would be when they would come in and have their see and treat and have their surgery done on that same day. So some of the obstacles that we came across was patients may not be able to make those both dates. They didn't want to participate in the see and treat pathway. So, the PDSA came in where I had to revisit some of those patients and phone more patients. So it was just a big cycle. Next page, please. When phoning patients, there is a certain criteria that we have to make. The government makes criteria for us and we need to follow them as NHS. This is just some of the bits of the referral see and treat cataract surgery that we must meet. So the patients need to be between 55 and 90. 90, it can go up. We have had patients in their hundreds, and providing that they're able and can walk from a chair to the table to have their operation done, then fine. I've got no problem in bringing those kind of patients in. Next page, please. This is the criteria that we have to fit for patients when I phone them up. So any difficulties in accessing the patients, or if they've had previous operations, complex operations in the past, or they need an anaesthetist, then that's something that we can't do just yet on the see and treat pathway. But moving forward, we never know. Next page, please. So the see and treat happened. 8 patients came through for surgery. 4 operations were happened. 2 were not suitable on the day because of other complications that I noted prior to them having surgery, and they needed a clinic appointment. This was actually a benefit to the patient because this is something that possibly that wouldn't have been picked up for months before they had to wait for an outpatient appointment. So actually that moved that patient on pretty quickly. One was on well, didn't require surgery, and one was on well, and one didn't require surgery on the day. Next slide, please. Okay, so I'll just come back for that one. But since doing that pilot, we have set up another pilot. So the second pilot is actually happening next week. And we've got a third pilot happening in June because of the success, and we have a different way of doing things. So the PDA cycle has completely just kept churning things out, and we're all coming up with different ideas to bring in more patients. So thank you very much.
Thank you, Alice. Great presentation, and also just really impressed how quickly you've kind of whizzed through this and really taken Kata on board. Buck, if you could just move on to the next slide, please. So in recognition of your efforts, Alice, we'll give you a purple belt in our Kata structure in terms of doing meeting multiple target conditions and being coached for that. So very well done in terms of that achievement. I think you've answered the question already, but I'm gonna pose it. What's Kata or PDSA got you doing differently than if you hadn't been using this technique, please?
So moving forward, we were only bringing brand new patients. Since doing this, we have realized that there are so many more patients that are waiting, that are just stuck in the system. We don't have enough time to have their cataract surgery. So we are changing the way that we're doing it. We're now training more people. So some of the optoms are going on cataract courses, and they are also I'm also learning teaching them how the See and Treat works, so that actually come the next pilot scheme, it will be patients who've been on the waiting list for a long time. So we're now looking at a different way of bringing the waiting list down, but from a different direction. So patients that have already been seen in clinic and put on a waiting list, bringing that waiting list down, as well as brand new patients that are coming in with cataracts. So we're kind of hitting it from both sides.
Fabulous, thank you. And just to sum up, because I'm mindful of time as well, because we've got a busy schedule, what I also particularly liked about your approach with this is the questionnaire, thinking about the patient input, and something we're kind of always very mindful of, and coach as well. So brilliant, you kind of got that voice of patient input, and also that idea of actually the one-stop shop and reducing the waste and the delay for patients in terms of getting their treatment more quickly, but then not needing to do kind of multiple trips. So that's all really positive. So thank you very much. There's a couple of questions in the chat that you're welcome to answer, Alice, through the chat, but I'm going to move us on because of time, if that's okay. So Buck, if we could just go to the next slide. And I think I've got Abby on to talk about an idea that's come out of the Precept T kind of program. So Abby, welcome, and the floor's yours.
Oh, lovely, thank you. So my name's Abby. I am one of the X-ray radiographers, and in our job role, we tend to go down to theatre an awful lot. So if you can hop on to the next slide, please. What we're looking at is we're going to work out whether it's more beneficial to patients if we train more people to upload images from theatre. So next slide, please. Thank you. When we go down to theatre, we use these things called C-arms, which take the X-rays, and some of them have Wi-Fi, and others we need something called a PAX port. The PAX port is a second picture on the tube coming down from the ceiling. The only problem is the PAX ports tend to be faulty an awful lot. So to counteract this and manage this problem, we upload our images to a CD, and then we go upstairs to the department and we have to upload the images from the CD onto PAX. So there's a real time difference between images that are sent via Wi-Fi, because they're on PAX immediately while you're still down in theatre, and then the images that need to be uploaded, it's very dependent on whether there is someone that's trained to do it, can do it at that time, which means the time difference between them can sometimes be days, or on a weekend out of hours, there's a huge delay. So hop on to the next slide, please. Thank you. So I sent out a little questionnaire to the radiographers via Teams to ask for their views on it, see if whether it was just that I'd noticed it or other people had also noticed it. So on the next slide, please, is my first question. I said, I asked people if they thought it'd be more beneficial to train more people. Everyone that answered said yes. So my next slide, please. I said, is this something that you'd be interested in? And most of the people said yes. A couple of people said that it isn't for them. It is quite IT skill based. So if someone's not interested, fine. And then on the next slide, thank you. I said, if we were to train more, would making a little step-by-step guide that people can refer back to, do you think that'd be beneficial? Everyone said yes. So on the next slide, please. The aim is to train more people to upload the CDs. Buck, I just saw your message. The CDs are reusable. They need to be wiped. So it is the radiographer's responsibility to ensure that their images they've taken in theatre are on packs in the correct patient packet. So the CDs can only be wiped once the radiographer is checked. And if that radiographer did a case on Thursday and then they're on leave until the following Thursday, that CD is out of use. So the aim is to train more people, so there are more people that we can go to. Out of hours is the main issue, so we're gonna see how many more people we can get trained, which would be done via a training program that's not in place yet. So that's something we need to work on to find. We're going to make a competency based what's it called, slide, and if you can follow that step by step, then you're competent and you can be signed off. So the next slide, please. Thank you. It's a great idea in theory, training people up. One of the biggest barriers to this is we need specialist IT access. So we need to get the IT team involved to do this, which can be a little bit difficult if we're getting a lot of people access, and it's going to be a bit tricky to police who we train, whether we make it a band 6 competency and everyone that progresses into a band 6 role has that. So more people that are in the department on the shop floor are able to help us out. Another big issue is if someone incorrectly uploads the images, they can go into different packets. So a theatre case could be floating around in some x-rays of a chest, and it is very, very nigh on impossible to retrieve them because they have just disappeared. And another key issue is only 3 computers in our department in X-ray have the CD port and the software on the computer to be able to upload these. And then hop on to the next slide, please. Oh, another issue is that out of hours, lots of the computers are shut down. So we'd have to figure out a way of keeping these ones on only for uploading the CDs, because our department is split into 2 areas, and out of hours only ED runs, and all of the computers that do the uploads are in the outpatients area. Thank you for listening.
Thank you, Abby. Very much appreciate the update. Some really good ideas there, and good to see that you're progressing and you're trying to kind of solve some of those issues as you go through. I'm just going to pick up on a point that Vix made in the chat, which is the same observation that I made, which is it's really good that you brought in the voice of the staff doing the process, because we talked about the patient voice. The staff voice is really important as well, and I really like your idea around that kind of standard work or that step-by-step guide, which is this is the best known way of us doing this, and then we can then use that to train people out as well. So it looks like Buck's got his hand up for a quick question just before we move on, but back over to you.
Yeah, I promise you a softball question, so here it is. You mentioned that there could be potential issues around incorrect uploads causing delays and being difficult to deal with. Do you think the risk of that would increase if you rolled out the training and made it more packs available rather than using the CDs?
I think if we had a wider range of radiographers that can upload, I think if we didn't have the competency-based training, kind of skills are left to relative to the individuals. So I think increasing the amount of staff also does increase the risk, and it is a pretty big issue. And if we had PACS ports that worked, or safety kit that was Wi-Fi based, there is, unless you've X-rayed under the wrong name, they're like the images are going to go into that correct packet. Yeah. The only way that they can get lost is the step between a CD and PACS.
Thank you. And thanks again, Abby. Appreciate you coming on. I'm going to move us on because, as I keep saying, it's a busy schedule, but thanks again, and best of luck with the next developments. And I think we can just move on back to the next slide. I've got a feeling we're on to Sharon, potentially Sharon and Kingsley. I think I can see Sharon on the call, all scrubbed up. So hi, Sharon, you're very welcome. The floor's yours around just giving your update.
All right. Hi. Hi. Hello, everyone.
Hi.
My name is Kingsley. I'll be presenting with Sharon. We both work in theater, anesthetic nurses. So our topic is adjusting breathing circuit changes times. So already, most time breathing circuit in theaters, both in anesthetic room and theaters, have been changed every Friday. And we find out that in general theater emergency, that it has been extended. Some emergency theaters, they do change it monthly because of they don't often use the breathing circuit. So I and my co-presenter were just proposing to see if this can be extended to other anesthetic rooms whereby these breathing circuits are not being used often. Please, can you go back to the introduction? Okay, this is the introduction. Okay. The aim of this project is to try to reduce the amount of plastic being discarded on a weekly basis in theaters of the hospital while still providing the best possible care for patients. Breathing circuits are changed every week, like I said earlier on, in anesthetic room and theater, irrespective of use. Meanwhile, in outside areas of the hospital, for example, endoscopy, IR, and cath labs, they are being changed once in a month because we don't often use it as we use it in every other theaters. I can't see this. Hold on. Okay, the circuits are changed only once in a month with no issues regarding the risk of increased infection rate because of the use of HME filters. This means that there is a chance that we are discarding this circuit unnecessary. So with this project, we are trying to reduce plastic waste and also save costs by proposing the adjustment of the change of circuit in the anesthetic room to monthly, bi-weekly, or weekly, depending on how it's being used. The next slide, please. Currently, general theater, like I said, for example, theater 1, event theater 1, 8, 16, and 7. In anesthetic room, we don't often anesthetize patient in the anesthetic room. So we change those breathing circuits once in a month. Likewise, the outside area, like I mentioned earlier, IR and endoscopy, cath labs. All other areas change circuit every week. Despite whether it's being used often. Sometimes after using it for a day, every week you end up changing this breathing circuit. We see it as a waste. In general, we have about 30 adult theaters with about 24 anesthetic rooms. Currently, only 5 anesthetic rooms seem to have the circuit changed monthly. This leaves many circuit breathing discarded either without being used or having only been used for a short time. Before this project, the orthopedic elective theater, that is Big Brain, and a few other theaters really changed their circuit, but continue to change them weekly. So my co-presenter will continue from the next slide.
Right. Hi, I'm Sharon. So regarding the project, we did a little kind of like test. First of all, we looked at the number of general anesthetics carried out in different theaters and in the outside areas, like the IR endoscopy. And although their circuits are being changed monthly, they still have more than 10 surgeries. Let me use 10 as a baseline. And then, so the plan was to look at those theaters and see if there was maybe a report on increased infection rates, leaving these circuits out for longer than a week or changing it monthly. I asked a few of our band 6 and our managers, and there's not actually any reports. I also did a few research online, and I was able to find out that with the right HME filters, there's a very reduced risk. If the correct HME filters are used, there's a reduced risk of spreading infection down to the breathing circuits. So we tried to carry out a monthly circuit change in Big Brain theaters. We did that for a few months, and the manager seemed happy with it. We tried to enforce it and make it kind of like a rule, but I just found out some days ago it's not being enforced because some people are not aware, and it has not been like passed down the line to new staff and all the staff. So the results, like I said, showed that some theaters really don't need their circuits in the anesthetic room being changed every Friday. Like Kingsley said, when we came, the circuits were being changed irrespective of whether they had been used or they hadn't been used. I tried to ask a few of the band 6s, how many times do you think a circuit needs to be used? Or on how many patients do you think it should be used before it's changed? And I gave them like some numbers, 5, 10, 15, 20. And according to them, 20 didn't even like qualify for you to change the circuit yet, because you can use it for some theaters like the orthopedic theaters, neuro theaters have way more than that number in a week, and they're able to use the theater, the circuit, unless it is soiled or contaminated maybe by a patient that has an infection or something. So if that didn't qualify, then why are we changing the circuits in Big Brain, in Freedom theaters that don't even use the circuits up to 5 times in a week? We tried to see if we could have a checklist, but that was one of the challenges we faced. The checklist was kind of knocked down because the managers felt that it might be like too much workload on the anesthetic practitioners, having many checklists to tick. And so there might not be enough compliance to get the data that we are trying to get. So for us, we believe more research can be done and then more modifications put in place and enforced. This will reduce the amount of plastic we throw away on a weekly basis. And it also reduce costs to a little extent. Next slide, please. So we were able to find out that if patients are relatively healthy and if the right HME filters are used, then these circuits remain safe to the patient and do not pose an increased risk of infection to them. Like I said, some of the challenges faced were the knocking down of the checklist because of workload on staff and too many checklists already and audits to be done. If this project is successful, or if we're able to carry on and change the circuits at changing times in some of the theaters, there will be less waste and some pennies saved. We hope more research can be done. We hope we can do more. We hope we can effect the change we want to see and save. Thank you.
Thank you, Kingsley, Sharon. Thank you. Great presentation. Really, really good idea. Great for the environment, but also great in terms of our needing to manage every penny this particular financial year as well, and also still thinking about how we kind of manage the patient elements and whether there's any risk here around infection as well. So kind of covered all the bases, and I really like the fact that you were looking at different practices practice in different theatres, and you were kind of learning from areas and you were kind of getting inspiration from there as well. So once again, very well done. And I wish you every success with kind of taking this further. Sorry if I'm moving things on kind of quite promptly, but I'm mindful of time today. So if we could just go on to the next slide. I think, Martin, you're with us to talk about another improvement idea. So once again, you're very welcome, and the floor is yours.
All right, thank you very much. So once again, my name is Martin, and then I work at Southern Hospital, which basically is HC, that is healthcare of the elderly. So we basically deal more with, how do you call it, the use of incontinent pads. So before I moved down to UHB, I was first working in a nursing home, whereby the usage of pad was, how do you call it, was really managed quite well. But then when I joined UHB, I've done a couple of shifts at different wards, including TEMA, TV ward. But then one thing I found actually interesting is that, but please can you move into the next slide? So one thing I found very interesting is that the usage of incontinence pad was a bit, how do you call it, was a bit at a very, how do you call it, fast rate, let me put it that way, because now we're changing incontinence pads, even when it's not really needed, we're still changing the incontinence pad. So the first problem, as I noted, the first problem I noted is that, one, as staff, many staff were actually putting incontinence pads on patients who actually don't deserve to be in pads without any further consultation. And what I mean by this is that normally when patients are admitted, we tend to believe that, oh, this patient is, how do you call it, incontinent. So we just put a pad on the patient without asking or getting consent from the patient. And then secondly, it's also been observed that most members do not consider the built-in indicators. And what I mean by built-in indicators is that when you take incontinent pads, they have these indicators that's normally it changes color. So if the pad is actually soaked, it changes color for you to know whether the pad, it indicates either the minimal level or the maximum level. So it helps us know whether the pad needs changing or doesn't need changing. And then thirdly, I also realized that most of we also kind of put, how they call it, the inappropriate pad on the patient. We don't actually use the correct size pads on the patient. We just look at the patient and assume that the patient can better fit in either extra large pads, small size pads, or medium pad. So when the patient, literally, maybe the patient can better fit in small pad, we end up putting, how do you call it, large size pad on the patient, which at times can be a bit, how do you call it, either ill-fitting or it doesn't fit the patient very well. So subsequently, it tends to soil, how do you call it, the bed sheet and then other consumables as well. And then most employees also don't know the sort of pads, their purpose or their situations in which they can be used. So back, can you please move on to the next slide? So now these are the type of pads I was talking about. So we have the wrap pads, we have the puller pads, and then we have the indicators I talked about. So the yellow one is a typical example of the indicator I was talking about. And then almost all these pads have indicators that literally tells we the staff whether the pad needs changing or it doesn't need changing. Okay. So when you look at the, how do you call it, then the wrap pads. So the wrap pads basically are for patients who are double incontinent. So if the patient, how do you call it, opens, how do you call it, his or her bowel, and then also pass urine as well. But so those patients are very good with the wrap pads. And then so patients who are single incontinent. So that is, it can be only how do you call it, single incontinent with bowel movements or probably incontinent with urine. Those patients are better off with the, how do you call it, with the, they are better off with the other side, other parts, not the, how do you call it, the wrap part. So back, please, can you move on to the next slide? So when you talk about the impact, now with the impact, I tackled 3 aspects of the impact. So now on the patient, so assuming a patient is admitted to, let's say, Southern Hospital, and then we assume the patient is incontinent. So we put the pad on the patient without consulting the patient. What do we think we are doing? One, we are depriving the patient of, how do you call it, the opportunity to be, he or she to be independent. And more or less like we are taking their independence from them. So so what they tend to do is that they become more reliant on us, which we don't actually want to aim at that point. And then also, secondly, now when you use incorrect part or ill-fitting part, what it can cause is that it can cause a bit of discomfort to the patient and also embarrassment to the patient as well. And then also, when you look at the, how do you call it, the cost level. Now, before, at the beginning of, how do you call it, this slide, the NHS, it cost the NHS about 80 million, how do you call it, pounds on incontinence parts alone. So if we continue to put pad on patients, people who don't require the pad, who don't use the pad, one, we are just costing the NHS more money. We are just making the NHS spend more money on how do you call it, areas which the NHS shouldn't spend as much as money over there. And then also, if you take into consideration the clinic cost of the materials. Now, the clinic cost of the materials and then disposal of excess parts. So mind you, it's more or less like a chain. So when you, how do you call it, we take the incontinence part, obviously we need to put it in, how do you call it, we need to put it in, how do you call it, sorry, clinical waste bin, we need to put this in the clinical waste bin. So the NHS is buying one part, also buying clinical waste bin. Aside the clinical waste bin, the NHS also needs, how do you call it, to fund the cars that come for, how do you call it, that comes to collect the clinical waste bin. And it's like I said, it's a chain of things that NHS spends so much money on, which shouldn't be the situation. And also labor costs for staff to required to change more parts that's required, and how the cleaning and disposal. And also when you look at the environment, now when you look at the environment, the NHS is one of the largest producers of waste in the country. So biohazard materials are disposed of by incineration. So what I mean by this is that now, once all these incontinent parts are taken and placed into the clinical waste bins and then taken to the dumping site, now obviously some of these waste are incinerated, and once they incinerate, what it does is that it generates this CO2, carbon dioxide, and other pollutants into the atmosphere. So the NHS has committed to reduce the use of incineration as part of the 10-year net zero carbon policy to waste emissions by 30%, and also save approximately 11 million pounds in the process. And back, next slide, please. So I developed what you call the that's the PDSA plan. So now with the PDSA, now I devised a presentation to staff on effective use of incontinent parts. So before I devised the plan, once I was able to, or once I noticed that the use of incontinent part is a bit, it's a bit of on high rise in the various wards. So I spoke to my ward manager, which we developed, how do you call it, a very good plan or very good good presentation to just present to the staff on the effect of that is abnormal use of the incontinent part. So I did a presentation to the ward staff on one of, it was during handover, that is when I did the presentation to the staff, and they were very engaging. So they did ask a series of questions, which I actually answered. And also regarding the study, so what I actually realized is that now there have been so much improvement, because now I'm hearing staff say that, or ask patients whether they use incontinent parts or not. And then if they use incontinent parts, what kind of incontinent parts do they use? And then what size do the patients normally use as well? And because of this, now I've seen that there is drastic reduction in the use of parts at Southampton Hospital. And then also we did a piloting, literally, we wanted to implement something here, but then we did a piloting on one of the patients. And when I talk about piloting, now we use a system here called System 1. And with the System 1, one thing about the System 1 is that there is a portion that is generated or dedicated to if the patient belongs to, or the patient is an ex-military personnel or an ex-service personnel. So we fill in that portion with the patient details, and then the NHS also pick up from there, and then literally speaks to Ministry of Health that one of their patients or one of their ex-service personnel came here. So this is the whole cost that was, how do you call it, or this is the whole thing, this is the whole money that the NHS spent on the person. which in turn Ministry of Ministry of Defense fund the NHS for. So because of this, that's when my ward manager and I decided that, okay, why don't we ask patients? Because if most of the patients who use pad, obviously some come from their home, so they've been the buying of pad have been something that they've been doing here for years. Some too come from nursing homes, some too come from various various homes. So when they come, we did a pilot on one of the patients who happened to buy his own pad. So we asked him if possibly can he still tell his next of kin to buy bring him more supply of the pad just for him. We just wanted to find out how much we are going to save for the NHS. And then the interesting thing is that because the patient was using his own pad, one, the NHS saved enough money. What I mean by this is that the NHS, what I mean by this is that now we're not using the pad from our supply, we're not using that. And then two, because we're not using that, then one, like I said, the NHS saved enough resources. And then two, we also saved enough pass supply that were used for other patients. So I believe that if the NHS is able to roll out a large scale that's regarding patients who already use incontinent pad, if we can literally roll out a program just advocating that if you are able to, because if you're using a pad, if you're able to bring in pad whilst you are inpatient, this will be very good. That will help the NHS save more money and more resources regarding the usage of incontinent pads. And then also, now when I also started, the trust, or when I got employment, obviously I was enrolled onto the different programs, that's basic life support, manual handling, and then other trainings. However, I think if if we can develop, or the NHS can develop an e-learning platform dedicated solely for the usage of incontinent pad, I think staff will be able to know, or staff will know staff will be able to know when and how to use the incontinent pad. And then also staff can also know the impact on if you use the incontinent pads abnormally. Staff can also get to know the impact of using these pads abnormally. And then also I also did something called I also updated our admissions checklist and then handover form. But please, this one. So now when we look at our admission checklist, so it just talked about the observations, height, CP, and all these things. But previously, if you look at the very bottom, there was no continence level. So there was no portion that was dedicated to the patient continence level, whether the patient is incontinent or the patient is continent. So I had to update it and added that one just for us to know that this patient is incontinent or the patient is continent. And then when we are also taking over from, we are taking handover from Derryford or UHP. So if you look at the handover form, previously there was no continence session. So literally we're just talking about diagnosis, previous medical history and stuff. There was no portion that was dedicated to taking the patient's continence history. So I had to also update that one as well, which I've provided a portion for the continence level, just to give us a fair idea of what and how, or what the patient needs, so that if the patient comes in, because you know that, okay, the patient is single incontinent or double incontinent, and the patient uses single size pad, okay, then we can ask the nurse of kin whether they are the ones who have been providing the pad, and if they are the ones who have been providing the pad, we then tell them that is it possible that they can bring more of the pad supply to the patient who has been admitted, and they are like yes, so they tend to bring some of the pad as well, and then we use it for we use it for their either their moms or their dads. And because of this, like I said, Southampton is actually saving much resources regarding the usage of incontinent pads. So Bucks, next one, please. So summary. So like I said, every ward needs to put much more focus on the use of incontinent pads, as this poses unnecessary cost to the NHS and as this cause unnecessary cost to the trust and then greater NHS. On average, each patient is supposed to use about 2 to 3 pads in 24 hours. But then it's surprising to see that because we use the pad. Because of the ways at which you use the pad, so a patient can use as much as 7 pads in 24 hours, which actually is uncalled for. And then also further improvements in this area could potentially result in much needed savings for the trust, as well as increasing patient trust. So that's a bit about, how do you call it, the usage of incontinent pads.
Thank you, Martin. Much appreciate your update and telling us about the opportunity around incontinence pads. I particularly liked your focus on patient dignity and about making sure that we're treating kind of patients with respect as well, and not assuming that they need something as well. So thank you for all of that. I'm mindful of time, so I'm just going to move us on again, but thank you for your presentation.
Okay.
Rob, if you're able to give us a quick whistle-stop tour in about 5 minutes or so, that would be very useful. And then I'll finish off the report out with the from the SRU. So Rob, the floor is yours, and welcome.
Thank you very much. So I'm Rob Calder, the support manager for acute medicine. So I'm deputising for Becky Greenwood today. So I'm just going to talk about the work that we've been doing across MRU and AMU to try and better support the flow from ED and improve the patient's timely transition through our care. Can I do next slide, please? So this slide is talking about the reasons why we need to improve. So obviously, as everybody knows, there's been a lot of pressures at the front door with ED, trying to improve the length of wait of the patients are facing when they come through our emergency department. So we're quite vital in regards to ensuring our flow across our floor, so across MRU and AMU, will also help with ED in regards to providing space and for further patients for admissions. The other area that we've obviously got in place is medical SDEC, which also helps with ED department. So any patients suitable for SDEC, transferring them across to them to have their treatment. Next slide, please. So here you'll find the PDSA cycle record. So this is what we've been working on. So what you see is in the green is the projects that we've been working on to improve the flow to support the front door. So I won't go through each one just because obviously I'm trying to speed up for time for Neil. And you'll see from the ambers, that's the areas that we are currently working on. So at the moment, we've just implemented a daily 2 p.m. senior clinician board round across the whole of AMU. So we start with the MRU area, talking about our patients that have been admitted via the emergency department, ensuring that patients are not having any blockages, so getting their investigations done on time, trying to chase up any senior clinician reviews, any clerking that needs to be done by our resident doctor team. And then we move on to our AMU area, so TAVI and Thrushall. So again, we'll then look at patients that are suitable for any discharges and trying to ensure all bed moves are being made. So identify the blockages and try and keep that steady flow across the floor. If there's any patients that need to be moved off to specialty areas, trying to ensure that all of those transfers are being made, they're being seen in a timely fashion. Another thing that we've also recently done is we've increased the size of our MRU. So that's gone from 22 spaces now to 27 spaces. This is in order to increase the amount of patients we're able to bring through the unit and provide a better stream for them whilst they're with us. And then we do have a couple of red ones there. So we are currently in the process of looking at trying to work on some other areas. So we're always looking for improvements within acute medicine to try and improve the flow. Sorry, let's take a breath. So next slide, please. So what you see from this graph is so our data collection started, so looking at the patients arriving and departing MRU. So what we've been trying to do here is trying to identify any patients that we deem as probably not suitable have come through the MRU pathway. So we're trying to improve the quality of the patients that are being referred via us, with them going through the correct referral stream. So was medical receiving unit the correct area for them to be referred to, or should they have been referred to medical SDEC? Or could they have had their care done in the emergency department? So we're looking at things like their length of stay. So if they were admitted to us and discharged quite promptly from the medical receiving unit, was that referral really needed? Also, we're trying to look at their pathway on the medical receiving unit to ensure that they're not spending too long on with us. So ensuring that they're actually getting prompt treatment when they're referred and investigations. Next slide, please. So again, this is just obviously a summary of what I've just said there. So the number of patients staying for 6 hours or less. Patients identified for specialist intervention, so I didn't say about that side of things. So any patients that need further referrals onto places like cardiology, neurology, ensuring that obviously they're waiting less than 50% of the time. Next slide, please. That is the end. So sorry I've rambled my way through. If you've got any questions.
No, Rob, that's been fabulous. Thanks for giving us the overview, and appreciate you whizzing through that as well. So a whole host of improvements there, and what I particularly like on the level 6 space across the whole floor is you and the wider team's enthusiasm for trying new things out, and MRU particularly is a little bit of a hotbed for that, but also some quite significant changes that have gone on TAVI and Thrushell as well, and you know, there's a couple of things that aren't moving and haven't moved in the right direction, but you know, that's how change works out. You know, we're successful with some things, we've got to plug away and try things with other things. That's nothing to be concerned about. It just means that we've got to come up with some further inspiration. So thank you, appreciate you jumping on, and we will move on to the final presentation, which is just an update on the event that's been going on the stroke rehab unit. So we can just move forward, Buck, and I'm expecting Craig Tucker to lead this bit. I don't know whether we've got Paul from my team down there, whether we're just going to switch sharing, and here we go. Look at this, Craig's appeared, and I think we're going to turn the volume on. Craig, lovely to see you. I'm in your hands, and let's just give this a go. So great to see you.
Thank you, Neil. Can I just check that everyone can hear me okay?
We can hear you fine. And we can see you fine too, and lots of smiling faces.
Well, good afternoon, UHP. Thanks for joining us. We're live at the improvement room in the Wembury Stroke Rehab unit here. And we're going to just take you round our room, the improvement process we've been going through over the last 2 weeks. This is like the formal conclusion to our 2-week improvement event. So everything's really raw, it's really live, and we're keen to share with you all the process we've gone through and what products and outcomes we've got to. Just to bring it round to what our purpose was, and our aim was to maximise how much therapeutic activity our patients receive whilst they're here. So I'm going to hand you over to Sophie, who's going to start us off and just talk around her area of the improvement room.
Hiya. So we started the project by thinking about the kind of behaviours that we wanted to establish. And within that, we had some common themes, and they included being open, being respectful, being honest. And we thought that those would really facilitate everyone to have a voice and feel like they're in a safe space and could think about new ideas, and all of them would be considered. So once we'd thought about our behaviours, we moved on to thinking about what was in the scope of our change. So within that, we had to consider what we could have an impact on that wouldn't then necessarily involve the other service users too much at the time. So things we were thinking of were things like equipment management, referrals, care plans, interventions, etc. So these were our first considerations before we started the whole process.
Fabulous.
Next thing, we focused on collecting some data to inform our process. Craig went to various other stroke rehab units in the area and collected information on how they do run their service. And a few themes that came out of that was that we were quite unique with our use of timetable. Our processes seemed to be most complex, and other units were utilising the semi-structured day with loads of group activities in their day. We also collected information on how much time we spend with every patient on a daily basis, and that just showed quite a bit of variability. So days were very different, but the common theme was that same days were looking very similar. So we focused our improvement on the Wednesday. And it looked like our average time that we were delivering to our patients therapy was 913 minutes per Wednesday. We also collected a little bit of information about how we delivered our therapy and why there may be reasons that we cut it short. And some common themes that are showing from that was that we do quite a lot of split sessions or shorter sessions than 45 minutes that we were scheduling for them in our timetable. And then a lot of our patients could not participate in full 45 minutes of therapy because of the huge fatigue impact that stroke had on them. And I'm going to hand you over the gate.
Thank you.
Hello. So the next part of the stage was we actually thought about what the voice of the staff were. So we thought about how the people's perspective of what they wanted to get from this session. We did it in an order so that the top level was what our main priorities were, and then kind of narrowed it down at the bottom were things that weren't so important. We then went and spoke to the patients themselves. We first of all divided up kind of 4 key questions that we wanted to work on and speak to those patients directly with. And the main things that came from that was that they feel that they get the therapy, but it's not very flexible. And they wanted to do more group work and be walking and be sort of sociable and being with other people. But also it was about that face-to-face and sort of organised interaction and kind of just keeping busy and getting out their rooms.
Fabulous, thank you.
Cool, and then following that, we made 2 process maps. The one above is the way we work daily, and this is the journey of a patient throughout their whole stay with us. And from this, we're able to highlight in green and red the bits that we don't like and we do like, and sort of where we could make some time. Where these were a bit lengthy, and considering the voice of the patients and staff, are able to us to highlight themes that we were able to then take forward across into our root cause analysis.
So from all of the information gathered so far, from the data, the voice of the staff, the voice of the patient, and the timelines, we then picked out the main areas that we felt needed work. They were the patients saying they don't get enough chance to practice walking, the patient's visibility of what progress they make, the patient's reluctance to get out of their rooms and engage in rehab, patients declining input, patients reporting not enough social interaction time, and patient fatigue. We then did a root cause analysis using the 5 whys, and a lot of things were said, but then we came out with 5 main themes from that we felt were the main areas that we needed to work on. They were that staff and patients don't have a joint understanding or a joint ownership of the rehab process, that there's a lack of flexibility in our day to structure around our patients, that we've got a large team that we need to organise, that the environment is not most conducive to group therapies, open gyms, and the sort of things we wanted to do, and that goals aren't as patient-centred as they could be.
Okay.
So that brought us on to come back as a group and talk about solutions. So we felt that some of our immediate solutions could be perhaps dividing the team and working our caseload slightly differently and having a morning handover for a quick setup of the day. And then we felt like over the next couple of days, we should also start looking at how we structure our goals and how the progress of those goals is communicated with our patients. That's something that we decided would perhaps take a little bit longer. And then something that needs a wider stakeholder is looking at more of a standardised induction process for patients when they come to us here on SRU. So we also needed to think about kind of the environment and who's involved with that. So on a larger basis, there's like rearranging the area here and how that would work for our patients. Again, that's a bit more of a long-term project. So coming over and looking at our first test, we decided to go with looking at the structure of our team and how we timetable. So usually we would timetable each day and that would be very rigid then so that we could meet the amount of therapy time. However, a lot of the things that came up were that this was too restrictive for us. So we decided to just carry on structuring some of the things that were concrete, but be a bit more flexible with day to day. So by splitting the team, we felt that we could change the way that we coordinate the daily input and just have quick handovers rather than a large amount of time being spent on timetabling. And that we could still carry on timetabling our breakfast and planned therapy paddles just to make sure they don't get missed. So we split into a green and blue team to match the nursing team to hopefully improve communication. And we've just tried to share out the skill mix on each side of those teams.
Perfect.
Hello, me again. So obviously we made two quite large and fundamental sort of changes to our practice, which we just went for. But then we have met daily since making that change a week ago to do the 3 C's and identify challenges as they've arisen. A few key things came up. So communication between the teams. The move from timetabling and knowing exactly who's doing what and when meant that we felt a little bit like we didn't know when we should be doing what we should be doing and who we should be doing it with, another colleague, they'd done it already. So that was one of the key challenges that we identified. The other thing was that the nursing staff no longer knew what we were doing and when, and that raised some anxiety for them. Because they're used to getting patients ready for a specific time, so they didn't know how to sort of manage that. And that patients and relatives no longer knew when the patient would be receiving their therapy or how much therapy they had received that day. So the sort of the communication side of it was the main concerns that were raised.
So, hello, this section is the voice of the staff. So this morning we all got together to discuss the positive and negative sides of the new structure. So our summary from that, the positives are that there's more meaningful activity for the patients, less stressful for us, more flexibility for us and the patients, and an overall engage in the improvement process we all felt. The negatives from that, communication challenges still remain, the actual time taken to do the improvement process. And some people feel that there's like a little bit of division with the green and the blue team, but that's something that we're going to work on. The products that we've made from this are colour-coded caseload lists, as Angela's holding up there, for the green and the blue. And then we've got colour-coded patient plan folders, visual aids to enable successful paddle and breakfast groups, and then an information poster just for the nursing staff to explain the change with timetabling. So overall, with our linking back to our main theme of, how do we maximise the therapeutic activity that patients have? So the data that Craig has pulled is that this, as an average Wednesday, that's how much activity time we've had, is 913 minutes. This Wednesday past, 30th of April, is 1,142 minutes. So that is a 25% increase in activity time for patients.
Fabulous.
Move on to the next section.
Okay, hi. So this is our action plan going forward. So we split it up into things that we want to achieve in 7, 30, 60, 90 days. The first colour coordinated visual aid of the priorities for the day. So we call it the ward sheet. The physios have started using it and the OTs are going to trial it as well over the next couple of days. With the goal setting meetings, we're going to remove the formal meetings and make the goal setting more meaningful with patients within sessions. Alongside that, we don't need to have a formal meeting to do the FIM outcome measure. We're going to do that just as part of our initial assessment, again, saving time. And with regards to the goal setting, we're talking about ways that we can get the patient's voice heard about how they want their goals set. Do they want them on the wall? Do they want them on a folder? How do they want to see their progress? We realised that we perhaps need to educate our rotational staff more on pushing patients to fatigue and what fatigue really means, and how far you can push patients. And we've also got a project within the month of reviewing our groups, open gym, and the getting up and ready structure. And then within the 60 days, we're going to create a induction process so that we show round new patients, next of kin, so they know the environment, to encourage them to use communal spaces, and rebrand the communal spaces. So whether that's a swapping of areas or just making it more inviting for patients to go to. And we're going to use patient information, so gathering info from patients when they first come to find out what the patient's normal day is, how that looks. Do they make a cup of tea first thing in the morning? Do they do that in the afternoon? What do they want to do within their day here? And then the longer term projects is just looking at the blue and green team and whether we rotate staff within those teams so people get to work with different people and learn from different people. And also reviewing our documentation, so our assessment forms and our manual handling plan, to try and make them more streamlined.
And back to me, which leads me really just to do the final thing of really to congratulate the team here and thank them so much for how well engaged they've been in this process. They've really embraced the improvement process, embraced the tools, even though it's something they're not necessarily so used to taking that amount of time over improvement. They've really taken the bull by the horns and given it a really good go, and they've did a really good product, and really expecting actually the outcomes to continually get better, really, because we've done this with existing resource. So those improvements were based on actually using our normal resource to actually do the improvement work in situ. So expecting things to continue to improve really over the next few weeks. So thank you all for listening. I'll pass it back to Neil and the team and to take over from me.
No, absolutely. And I think, first of all, I think we just need to do a collective round of applause from everyone in the group and in the room as well. That was a fabulous report out presentation, really well done. And I think that I'm just really blown away by that. So well, it was textbook in terms of the way that you covered all the various elements off. And I think let's just focus on the fact that as a result of you being brave and, creating the right environment to look at this, your patients are getting 25% more therapy input. So what a fabulous difference then that's making to patients. And also it's kind of that mindset of actually the way that we kind of organize and we do things is really important in terms of the the benefit we get for patients as well. So so thank you. And as I said, I'm just kind of literally blown away with that. The fact that you've got patient input, staff input, you've got data there, really clear on your plans as well. That's a fabulous piece of work. And I definitely need to get myself down at some point just to have a little bit of a nose and see kind of what you're doing and have a little bit of a nose for myself. Though, any comments from the wider group just before we close? Because I'm mindful that we've run over by a little bit. I suspect there's Vic, you've got a question.
Well, not a question. I just wanted to say a huge well done to the team. So I was really lucky and privileged to be able to spend the first day with you. And unfortunately, due to other commitments, I've not been able to make it down. And just the way that you guys have really come together, thought outside of the box, and really utilized the data and the feedback from everyone involved to come up with some really brilliant solutions that have had a really positive impact on the patients. Like, a massive well done to you all. I'm incredibly proud of you all. And I too am hoping to come down in the next couple of days just to come and actually see you all again personally and congratulate you again in person. So well done, everybody.
Thanks, Vic.
Yeah, well done.
Actually leaves me just to kind of thank you guys as well as the Quality Academy as well, because I know I gave very short notice of the request for some assistance, and he was able to adapt quickly and come and give some support, which meant that we actually achieved a lot more from this and delivered much more output. So, particular thanks for Neil for being so accommodating, and Vic and Paul for coming and supporting us down here, and really keeping us going on the project. So yeah, thanks.
You're very welcome, and thank you. And I think kind of the final point I'll kind of leave things on as well is, Obviously, the trust has set us all collectively that challenge this year to kind of clinically transform the way that we deliver services. And this for me is a real textbook example of a team being really kind of engaged, thinking about it, you know, challenging some of the givens, thinking about doing things a little bit differently. And the other thing, you know, at that kind of level that comes through really strongly for me as well is just kind of the values coming through. You're thinking, you know, that listen, learn, improve, and the way that you're interacting with each other kind of just felt like a really nice kind of supportive environment. So thank you for being brave. Thank you for taking the change on. Cool. I think we will jump back to our slides. Thanks, Craig and team. See you soon. And just quick reflections from me. So what a high to finish on, but I also don't want to underplay the other contributions we've had today in our bumper report out. This is how our list is shaping up for June. I'm sure it will change as we kind of get close to the time as well. Sorry to overrun slightly. That's probably a note to self for me to manage time a bit better for the next session, but you know, I'm on an improvement journey too. But thank you for your time today, and let's carry on improving, and I'll speak to you all soon. Thanks everyone, have a great day.